Hello and welcome to episode 2 of New Nurse IRL. Today we're going to talk about giving and getting report. So this is a very important skill that nurses need to know, especially when you're a new nurse. It could be daunting because you might be nervous or not sure where to really start. So to make it easy, I think I'm gonna start off by just having an example that I wrote here. So I'm gonna give report, I'm gonna go over it, and then I'm gonna break it down so that it's easier for you to understand. Okay, let's go. So let's pretend like we're in room 420 and we're giving bedside shift report, okay? So Mr. Robert Trevor, he's a 67-year-old male, full code, allergies to peanuts. He's coming in for COPD exacerbation, anaphylaxis, and fall. So what happened was he was at his grandson's first baseball game. He ate Cracker Jacks not knowing that it had peanuts, so he had an anaphylaxis reaction, which triggered his COPD as well. And all of that, he tripped on the bleachers and fell on his right side. So Mr. Robert had just had a very eventful day, okay? He has a history of COPD, diabetes, hypertension, hyperlipidemia, neuropathy, and he's a current smoker. He said he's not gonna quit because it helps him with his stress, even though I told him that it is not good for his COPD. But he understands, apparently. So he has ANO times 4. He has numbness and tingling to his lower extremities, which is chronic from his neuropathy. And he has pain on the right side of his arm and legs. That's because he fell on that side. They did do some x-rays that were negative for fracture. So for pain, I gave him tramadol, and he also got gabapentin for his neuropathy. So he said that his pain went from like a 6 to a 4. He's been running sinus tachy, low hundreds. For his hypertension, I did give him amlodipine. Originally, he was on the BiPAP, but I got him in the 3 liters oxygen via nasal cannula, and he's been doing well in that setting, around 91-92%. He's been getting Solumedrol as well. He's ACNHS. Last blood sugar was 315. I covered him with insulin. We switched it to a high sliding scale, and you're also going to give him some Mantis for tonight. So his last bowel movements was several days ago on the 20th. I did give him Miralax and Colace per patient's request because he was feeling constipated. And he's also getting Pepsid. He's on a carb-controlled diet. He goes to the bathroom and he uses the urinal sometimes. Oops, I put the Miralax there. We have consults for pulmonary. I called that already. The admitting doctor is Dr. House. He's a 20 left AC and 20 right wrist with normal saline, running at 75 on that right wrist. For VTE prophylaxis, he has Lovenox. His skin's intact. No bruising that I saw on the right side or anywhere. He does have a Nicoderm patch to his left deltoid because he says he smokes about a pack a day. So normally he's a walkie-talkie patient, very independent, but because of the fall, he just has some weakness. So I would say 1 assist with a walker. He's been doing okay with that. Chest x-ray showed emphysema, and I told you about the negative fractures on his right side. So the plan is for pulmonary to see him. We're going to continue with the steroids, Pepsid, and the breathing treatments. Hopefully we can wean down his oxygen. And then we put in PT and OT as well. They saw him and they were recommending home health with a walker, so case management is consulted for that. Okay, any questions? So that was an example of how I give report. Now you can either be somebody who doesn't give a lot of details, or TMI, too much information during report, or just right. I feel like when I give report, I give a little bit extra detail just for fun, so I land somewhere between here. But if you're giving a report, try to be at least in the middle, right? You want to give the pertinent information that the next shift needs. So how are we going to break that down? You probably heard of S-bar before. situation, background, assessment, and recommendation. So let's start with the situation. Basically, what's the situation? You're gonna tell the upcoming nurse basically, well, you know what room you're in, but patient's full name, the birthday, their code status, and allergies. A lot of the times people don't talk about the allergies, but it is very important because in this instance, he's coming in because he ate peanuts and that's why he was in anaphylaxis, right? So you're gonna tell, it's basically like the chief complaint and what they're diagnosed with. So I kind of told a little story about that, how he ate the peanuts, he fell, and then he had the COPD exacerbation as well. So in terms of background, that's the patient's history. So in this case, like the COPD, diabetes, all that stuff. Assessment is my full assessment. So basically, when I give report, I start like here, here, and then work my way down with my assessment, down. And then recommendation is what are you recommending to the next shift or what the plan is. So for me, I actually, it got erased, but I kind of like to say SBARP. That's supposed to be a P, it got erased. So plan. So with your recommendation, let's say you were working night shift and the patient was asking for something to go to the bathroom with, and you couldn't get a hold of the provider or something. It's not a life or death situation in that point, so you can ask the next shift, hey, can you please ask the doctor something to go to the bathroom with? I tried prune juice and it wasn't working. But I feel like P should be added because that's the actual plan, which is right here. Oops, I forgot to talk about the labs, which is very important. So when you're giving a report, you don't have to give every single lab, but just pertinent ones related to the patient. So in this case, I would have said, also the potassium was 3.4. I replaced it. I gave 40 MEQs or whatever it said on the chart. And I put a repeat draw for 2000. So that's also part of the plan because I replaced this. So I'm telling you, make sure you watch out for when the phlebotomist draws it so you can double check that the potassium is normal. Giving and getting report as well. You're gonna see how other people do it. So like I said, most people are in this, you have to be in this spectrum. You either give a little bit more information or sometimes not enough. But for me, I kind of like to give extra details because it shows you what I did. So anybody could just get this paper and read it, right? But I like to include the medications with the body systems. So if you heard what I said, like, oh, I gave tramadol because of the pain, gabapentin for the neuropathy, amlodipine for the blood pressure. It's kind of like, okay, the patient was constipated, so what did you do about it? The patient was in pain, what did you do about it? Well, I gave this medication, or maybe I gave them an ice pack or a warm pack. But like I said, as you're going down, you're telling them what did you do in your shift to help the patient. Okay, so giving report is one thing, but getting report is another. When you're a new nurse, a lot of the times it may seem like the nurses talk too fast and it's hard for you to write everything down. So in that case, if you really can't keep up, make sure you tell the nurse. They should know that you're new. So just be like, hey, can you please slow down? I'm still writing things down. But this is the time to make good habits and learn common abbreviations. Because your goal is, once you're more of an expert nurse, you're gonna be faster and more efficient when you're writing report down, okay? So there's a whole bunch of abbreviations. There's a lot online, but it seems like when I was looking stuff up, they only had a few and nothing was really like this much in one page. So I just wrote down most of the basic abbreviations that I tend to use. It's a lot. So let me see if you can see this. Maybe like pause the screen and take a screenshot. I don't know if you're gonna be able to read this, but this will be helpful when you're giving report. So starting off, of course, you're not gonna learn all the abbreviations, but the more you do it, the better you're gonna be. So, and for instance, like you're not gonna write down stroke, you're gonna write down CV. You're not gonna write out hypertension, you're gonna write HTN. So that will help a lot in terms of just writing things down quickly. Like over here, you saw how I said DM, diabetes, DM, hypertension. ANO times 4 is alert and oriented. BLE is bilateral lower extremity. If it's a certain side, like left or right, I'll just put L or R and I'll circle it. There's just a whole bunch of things that you can learn. You can also make up your own abbreviations, but just remember them because it's yours, right? It's gonna be your report sheet, not anyone else's. So as long as you know what you're writing, that should be good. A lot of the times, even the medications, I'm not gonna write down amlodipine, I'm just gonna write like AML, and I'll know that that's the medication that I'm talking about. So if it makes sense to you, then you can shorthand things. But don't write things if you don't know what it's gonna be, right? Example is like bathroom privileges. You don't wanna take 20 seconds writing bathroom privileges. Just put BRP, just like that. BM, bowel movement, or draw heart for cardiac. There's a lot of different ways you can go about it, really. So when you're getting report, it's really best practice to do bedside shift report because you can look at the patient and their surroundings, right? So when you're getting report, the main thing is, yes, you're trying to write everything down while the person's talking, but also looking at the room and the patient, right? So when you're getting report, they're probably gonna say the same thing as I did. But as that nurse is talking, you wanna look at the patient. Are they sleeping? Did they open their eyes as soon as you walked in? And then verify what the nurse is saying too. So in PCU normally, or other critical care areas, most people are in telemetry, right? And sometimes med-surg patients are also in telemetry. So if they're saying like, oh, they're sinus tachy, but then you look on the monitor and it's AFib, you can say right at shift change, like, okay, has that patient been on AFib or is this new, right? So you're confirming. So just because they say sinus tachy, you're not just gonna write sinus tachy. You're gonna look at that monitor at bedside and see, okay, maybe it's not correct, or maybe they just went into AFib just now. So you wanna know stuff like that, right? The other thing, let's say they'll say 3 liters, but the patient's on room air. Okay, how long has the patient been on room air? Or maybe the respiratory therapist just removed them from the oxygen, but do they have an SpO2 probe, and how is the oxygen right now on room air? Something like that, right? If, let's say the patient was bedbound and they're on a PureWick or something, you want to check if the suction is connected so that it's not spilling and you come back there and you're going to have to clean up the patient. Or is the urinal next to the patient so it's easy access? Are there any safety concerns? Is the bed alarm on? So stuff like that. The main thing I want to know when I'm getting report mainly is what the patient's baseline is. So in terms of like mentation, are they really ANO times 4? Because if I do my assessment after the nurse leaves and the patient is confused, is it confusion because they have history of dementia, or is this something new that I need to be concerned about, right? And the other things. I talked about critical labs. So like I told you, in terms of over here, the potassium was 3.4, not critically low, but I did replace it. So I told the coming nurse what time it was going to be redrawn. And this is also the time where you can verify the drips. So they'll probably tell you, let's say patient's on heparin drip and it's going at 9 units per kilograms per hour, which is this many mLs per hour. So you're writing that down on your paper, but also verifying on the actual IV pole. And sometimes you have to co-sign for those strips anyways on the computer in the room. Let's see, what else? And as you're getting the report, the main thing also is thinking of the plan. So that nurse might give you the plan, or you can start thinking of what other needs the patient has. So let's say for this one, there was no order for PT and OT, but you know that the patient fell. So I'm thinking ahead, like, they will need this eventually, so I'm gonna make a box PT/OT, because when they get discharged, they need to be evaluated to see if they need home with home health. Because a lot of the times we're so focused on what's going on now, but normally if you're on the floor, the point is of course treating the patient with medications and all their treatments, but it's like after they get better, what's the plan? Because you don't want to wait until last minute and you're putting all these orders for poor physical and occupational therapy, so they have like 1,000,000 orders in one day, and they're trying to see all the patients to be evaluated to be discharged that day. So if you can get ahead of the game and put in the orders early, you can have a plan to see what the patient will need. And that plan might change as the patient stays, because let's say he somehow deteriorates and will end up needing more care, then we can worry about that. But they're going to end up following him throughout the hospital stay. Okay, so in conclusion, giving and getting report, like I said, is very important, especially for a new nurse, because you're learning so many new words, so many new abbreviations. Take it one day at a time. But the more you do it, the easier it'll get, you know. But basically, know the situation, the background, assessment, and recommendation, or the plan for the patient. Thank you for watching my video.